So I'm going to talk about a study that we did using data from a large care home chain to investigate the burden of COVID-19. So I think it's probably everybody here is aware care homes were hit particularly badly during the pandemic. And what this graph shows you is the number of deaths in care homes this year compared to last year. So the green are all deaths, blue are COVID-related deaths. But what I'd like to draw your attention to is the red line, which shows when the government's whole care home testing programme was introduced in England. And I think what is quite striking is that that programme that aimed to test everybody in the care home, so this is staff and residents, didn't come in until after the peak of the pandemic. And so clearly, if we want to do research where we're trying to estimate the burden of infection based on lab tests, we're only going to see part of the picture if we don't take account of the fact that testing was late coming in. So how can we try and get a handle on the burden of infection in care homes? Testing in care homes has been quite a complex process, and obviously setting up capacity at the beginning of the pandemic was quite a challenge. And so the options that we've got are using Pillar 1 test results. And so that's largely based on results from people who were admitted to hospital or as part of outbreak investigations that happen when a care home lets Public Health England know that they have an outbreak. And certainly at the beginning of the pandemic and for some time through it, that was a maximum of 5 tests per care home. So clearly only part of the picture. From around April the 30th, the whole care home testing programme came in that I've already mentioned. And so that gives you data on everybody in the care home, but at least at the start, it took quite some time for that to be rolled out as a regular thing. So challenging using lab data to know what's going on. So what we did in our study, or what we aimed to do, was to try and get a handle both on the number of suspected infections and confirmed infections, to try and get around this problem that we know if we just use lab data, we're going to be missing a big part of the picture. And so we looked at the incidence and risk factors for infection and mortality, but we also did some qualitative work to understand the impact that the pandemic was having on staff and residents and the ways of working in the care home, but I'm not going to talk about that today. So a bit about the care home chain and the data sets that we had access to. So we worked with Four Seasons Healthcare, and we were very fortunate that they, early on in the pandemic, set up a bespoke system to try and record the number of suspected and confirmed infections and deaths. And the way this worked is that care home managers were asked to report daily tallies into the regional managers, and then they collated all the information in that way. We also were able to access their administrative data sets. So these are largely used for billing purposes, but it gave us some individual level data on demographics, dates of care home entry and exit, clearly important for incidents, and also information on care home characteristics. So the care home chain also has an incident reporting system, and so that provides data on things like falls and infections. And so we also had access to that too. Four Seasons has care homes across 3 of the 4 nations, so everywhere except Wales. And there were basically 2 ways that we could try and use their data. So the first was to use aggregate data. So this is based on the daily tallies that I've just talked about. And that gave us information on everybody in the care home during the period that I've mentioned here. But we also had this incident reporting system. And so what that does is give you information on the subset of residents who are in private beds. So it's the majority, but it does mean that we were missing information on 855 individuals who were in beds that are contracted to the local authority. And it's likely that those individuals are probably different from the people that we've got information on. So it just starts to show some of the challenges of working with this kind of data. So one of the first things we did was to try and estimate cumulative incidence of infection in staff and residents. And so what you can see here are the blue line are individuals with symptoms but who were not tested. Red line are people who were tested and had confirmed infection, and green are deaths. And this is looking from late in March through to June. And I think what is quite striking is that you can see we see a very high number of people with symptoms who were not tested, but also a lot of infections. And it starts to give some insight into the likely proportion who were not, case under ascertainment. So to give you some numbers, we found that around a fifth of residents and 16% of staff had symptoms compatible with COVID, and around 10% of residents and 5% of staff had lab-confirmed infection, and that accords with data from our national surveys. We also looked at mortality. This is again using the daily tallies, and we found that there were about 6% COVID-related deaths, 526 in total, and about a quarter of those took place in hospital. But what was really striking is that when we compared the rate of infections in our care home population to the general population based on the same time period in the ONS's household survey, we found around a 13-fold higher rate of infection. So it really underscores how the very heavy burden of COVID that was experienced by care home residents. We looked at case fatality. So this is now just based on the incidence data set that we had. And you can see overall, we had 36% of individuals with confirmed infections dying, and a pattern, as you might expect, with increasing age, but very high case fatality in this population. And something else that was also striking in our data is that if we looked at the individuals who had lab-confirmed infection and we compared those who had asymptomatic infection versus those with symptomatic infection, we saw a really stark difference in mortality. And you can see that those individuals with symptomatic infection were much more likely to die. And clearly digging into this in terms of what's going on from the immunology side of things is really important when trying to think about how to treat these individuals. So to conclude, we found that around 1 in 5 residents in our care homes had symptoms of infection during the pandemic. And this really points to a very heavy burden of infection that was underestimated, partly due to lack of testing, but also because we know that there's a lot of asymptomatic infection. We found really high case fatality, but our estimates, although at the higher end of what we've seen in data from other countries, they were still comparable estimates. And we found this very striking finding of the increased mortality in people who were symptomatic confirmed versus those who were asymptomatic. I think one of our key reflections was that our ability to tap into this active surveillance system that had been set up by the care home really provided very unique insights into the burden of infection in a way that wouldn't have been possible if we just used laboratory data. So thinking about the implications of this work for future research in care homes, well, I think probably the most striking thing is it shows it is possible to get data out of care homes rapidly and to do analyses that can inform policy in this way. But, and I would really caveat this, that it's extremely difficult to access reliable individual level data. And we had to do a lot of work to try and get this into a format so that we could be sure to be confident in the estimates we were presenting. The only reason we could do this was because we had a strong existing collaboration with Four Seasons Healthcare, and building on that, we found when we published this as a preprint, it got picked up rapidly by The Guardian, and Four Seasons came under quite heavy criticism because we had some findings around occupancy and staffing levels. So it's a challenging context to work in. The data sets are complex, and so understanding their limitations is critical. But also, I would point out that we've now started, as part of the work in the pandemic, working with independent providers as well as care home chains. and it's really shown it's relatively easy to work with large providers who in care home chains, but much, much harder to try and get equivalent data from smaller providers. And so there are real challenges about how we get generalizable findings across the care sector. So I should point out that this work has been a major collaboration, and colleagues Peter Duty-Magny in particular have played a major role in this work. So thank you, and I'd be happy to take questions.